Good evening, friends. Today, I welcome you to the 4D program, which is Details in Diabetes discussion, which is 52nd in number. And we'll have today discussion on the type 2 diabetes in India, challenges and possible solutions. And for that, we have a very talented speaker, Dr. M. Hanumant Rao, working at Arvinda Diabetes Endocrine Clinic in Ongole, Andhra Pradesh. He did his MBBS in 2004, did MD in 2014, and finished his DM Endo in 2021.
Thank you very much for the introduction, sir.
So today is going to discuss to us about the diabetes challenges that we face and what are the possible solutions. We all know we have recently data from the ICMR which showed that in the 28 states and 8 union territories and 100,000 representative sample from India, the prevalence of diabetes is 11.4%, hypertension 36%, obesity 40%, and the central obesity is to the tune of 46%, and dyslipidemia 81%. So that's such a high prevalence of various problems of diabetes. And what are the challenges is what will be discussed today. And I turn over the podium to Dr. Hanumantarao to do his deliberation, and he'll come back again for the question and answer session. Over to you, Dr. Hanumantarao.
Thank you very much. My honor to present this topic on this body forum. So, I'm honored to be addressing you today on this critical topic of diabetes care in India and challenges and possible solutions. So, diabetes often referred to as a silent epidemic. It has become a significant public health concern in India. However, as we navigate this landscape, we encounter barriers that impact quality of diabetes care and hinder efforts to improve metabolic control and self-management. Patient-related barriers cast a significant shadow. So, lack of awareness about diabetes care, risk factors, economical stress, denial of risks, and challenges of changing behaviors and sustaining these changes pose significant hurdles to the diabetes care in Indian patients. There are some rural barriers further compound this complexity. High rates of illiteracy in villages, poverty, diverse socio-economical strata, and a multilingual population, along with cultural, religious, and customary beliefs, can hinder effective diabetes care in Indian population. Even the medical profession is not immune to these challenges. So, medical training often focuses on acute care only. Even nurses find out it very rewarding, and the paramedics also train for acute care only. So it is also pose a barrier to give the chronic illness care in Indian population. What are the solutions? So, as we identify the challenges, we must also pave the way for the solutions that offer hope and progress. Education emerges as potent weapon in the battle, in this battle. So, rising awareness about diabetes risk factor is essential. So, it is the most key point to educate the population. Empowering both healthcare professionals and public with knowledge can be a catalyst for this change. So, training patients to become effective self managers is another pivotal strategy to achieve diabetes care in India, and empowering individuals to take charge of their health and disease management can significantly impact glycemic control and overall well being of this patient. So, structured care delivery systems play a crucial role in this ensuring the healthcare reaches all corners of our country. So, the development of systems that address unique challenges, possibly by different regions, language, culture, and customs, can be a game changer. Moreover, the managing cardiometabolic risk factor is integral to the diabetes care, because heart rate risk of the cardiovascular, these risks are very high in diabetics. Early diagnosis and management of aggressive management of glycemia and associated cardiovascular risk factors are paramount to this strategy. Let's discuss strategies to manage prediabetes. So, research has firmly established a link between prediabetes and cardiovascular complications, which is underscoring the need for early intervention in these patients. So, major medical organizations, American Association of Clinical Endocrinologists, stress the importance of diagnosis and treating the prediabetes. Following their guidelines can help prevent future complications and alleviate the burden on our healthcare system. So, managing prediabetes begins with lifestyle modification, encouraging to individuals to engage at least 180 minutes of physical activities per week, and adopting a balanced calorie intake forms a bedrock for this management. For those who are obese, anti-obesity drugs are pharmacological agents like metformin, pioglitazone, liraglutide, or carbos may be considered in these people, in these patients. For those who require additional support, advanced measures like bariatric surgery can be offered those who are needed. So coming to therapeutic strategies of type 2 diabetes, we found a wealth of innovative medications and medical therapies enhance the glycemic control and overall well-being. So novel medication therapies such as DPP4 inhibitors, GLT2 inhibitors, and GLP1 receptor agonists can which can regulate and restore the ingredient function. So additionally, early initiation of combination therapy such as metformin, GLT2 inhibitors, these fixed drug combination not only achieves early efficacy and also reduces the risk of hypoglycemia and cardiovascular events and also renal failure. So we must initiate in early in the course of the diabetes. So by leveraging these advancements, we empower patients with effective tools to manage their condition and improve their quality of life. So coming to end of the session, we must address about the patient education empowerment and also telemedicine strategies. Patient education and empowerment serves as the cornerstone of effective diabetes management. However, challenges persist even with this, especially in terms of facility and manpower availability, even in the major cities. So, prioritizing awareness campaigns, accessible patient education programs can uh, bridge this gap. So, entering telemedicine, a transformative strategy that transcends physical barriers. So, this telemeds gained popularity in the times of COVID-19, and also now it's shining. Um, this offers promises closer monitoring, timely intervention, and global care, the care of individuals with concomitant chronic conditions like diabetes. Over the past decade, numerous studies have validated the feasibility of telemedicine and efficacy of this telemedicine in diabetes and diabetes management. Integration of the patient education and empowerment with the power of telemedicine, we can achieve a greater control of diabetes in Indian population. Thank you for the active engagement, and now like to invite you for the questions you may have. Thank you
Thank
so
you.
much.
Thank you, Dr. Hanumantarao, for for an
Yes, sir.
elaborate discussion on the challenges that we have in managing patients of diabetes in this country. Okay,
Yes, sir.
we begin with, let me ask you the first question. Why diabetes? Why is India labeled as the diabetes capital of India, despite the fact that we have a high levels of malnutrition in this country?
Yes, sir. It's true, sir. India's diabetes capital status is attributed to complex interplay of factors, including genetic predisposition to diabetes, rapid urbanization, and sedentary lifestyles, and also nowadays the dietary shift toward the um, high calorie and less nutritious diet. All these are posed towards obesity and also type 2 diabetes. Even we have, yeah, various parts of India have malnutrition. This both highlighting the burden of the disease, sir.
Yes, you're right. We have the classical Indian phenotype, which
Yes, sir.
is the cause for the diabetes explosion in this country. And we get
Yes,
diabetes at early age, as you rightly mentioned, is urbanization and also consumption of food, which is processed, highly processed. And in
yes, sir.
fact, Dr. Mishra had shown patients from Delhi where they consume food for just 10 rupees and the lumps a large sumptuous amount of food. And this food actually is highly caloric and it is highly processed, and people sacrifice the nutritive value of the food to the cheap food, and that's why the calorie consumption actually goes up. There's also malnutrition related diabetes in our country, which could be either FCPD, which is seen in South India, which is the fibrocalculus pancreatitis because of consumption of cassava, and also there's a protein deficiency itself can cause diabetes. There's also extra components in our patients. And I think the most important factor also the lack of physical activity. People have become very, very inactive. They have a lot of TV viewing and they watch mobile phones all the time. And they have the disruption of circadian rhythm that also contributes to the high degree of diabetes in this country. Okay. Now
Yes,
let's
sir.
turn on to the next question. Then, how can healthcare providers the issue of medication adherence in the individual with type 2 diabetes? How can we address this issue?
Yeah, it's an important and we need in daily day practice, sir. Healthcare providers can enhance medication adherence by offering clear explanation of treatment benefits and simplifying the medicine regimen, and also we should involve the patient in the decision of the treatment, so that they will be more active in this participation, and they will adhere to this management disorder.
Yes, there are a lot of myths about diabetes people spread about, and therefore I think the education forms the most important hallmark in having the good adherence. There's a good data done by Jennifer Polanski. She is a diabetes educator and she looked at patients of diabetes and she realized why these patients do not take the medication. There could be either a primary non adherence or a secondary non adherence. And what she found, there are three reasons why patients don't take the medication. The first, she said, was there's no shared decision between what you advised the patient and what patient understood about the management of diabetes. So there should be a shared decision concept between healthcare provider and the patient. And second is the patient must be informed about the side effect. For example, if
Yes,
you
sir.
write HGLT2, you must tell the patient ahead of time that you're going to get mycotic infection. And if you get one, how to deal with it. So if you can pre-sensitize the patient before you start therapy, then maybe the patient will accept the medication because he knows, yes, my doctor has told me this, that this is a possible side effect. And then thirdly, the cost of therapy. You might write the most expensive and the most effective drug. When the patient doesn't take it,
Yes,
then
sir.
again the adherence comes into question. So this is the Jennifer Polanski. She is the diabetes educator from Canada. She studied 140,000 patients and she came to these three conclusions. So I think every healthcare provider takes care of these three aspects. maybe we can improve the adherence of the patient so far as the treatment of diabetes is concerned. Now let's move ahead, and there are some barriers which are there while implementing lifestyle, diet, and exercise. And how do you redress them, or how do you address them when managing the patient of diabetes? The lifestyle, the diet, and the exercise.
Yes, sir. Barriers to lifestyle modifications, including the lack of awareness, sir, first, and the culture and social influences, and also in this busy life, time constraints, and also economical factors, and also limited access to healthy food options, and also exercise facilities, sir. These may pose barriers to diet and exercise. Yes, sir.
Yeah, I think you're right. I think most important, of course, is the diet, where the patient should be given in such a diet where the patient will follow it. If you make it very difficult pattern of a diet, then many times patient won't follow it. He'll do it for a day, two, or a month at the most. Afterwards, he'll give it up. So there should be one which is easily adjustable, adaptable. That's the most important aspect. And the exercise is the what is I believe in the group exercise. As in some places in South India, they made a lot of playgrounds and they play a lot of music, the devotional music, and people go there for a walk in the morning. And when they go in the group, they can listen to the devotional music and continue walking. So this is what is called group activity, where many patients are involved and there's some kind of a competitive skill between the patients to adhere to lifestyle. And that's how you can make it interesting so that the patient feels, yes, this has a lot of benefit. And if there's some patients who show the benefit in reducing the A1C, blood sugar, and also the weight of the patient, that will be a kind of encouragement. You can showcase such patients to them so they will definitely adopt. And that's how the importance of the exercise and the diet management, where patient has to see to believe that this is doable. If there's something patient feels is beyond the reach of his man, I mean, if you give a very complicated schedule, then he will not follow it. So make it very simple and effective.
Yes, sir.
Okay, that's fine. Then what are the key components of successful telemedicine? You did mention about telemedicine in the management of diabetes. We adopted this policy during COVID time where we could not have access to the patient. So what are your points about the successful telemedicine therapy in diabetes?
Yes, sir. A successful telemedicine program should include remote monitoring of glucose levels, regular communication between patient and healthcare provider, and they should access to the education and resources, and the medication adjustments, lifestyle counseling, and also the ability to address the patient queries. All these it should address that, so it will be successful.
Yeah,
What is it?
after legalization of telemedicine in our country during the COVID time, it has opened a big vista for the management of diabetes patients. And that's especially from the monitoring point of view. We can monitor these patients effectively. We can teach many aspects of diabetes during telemedicine. And also, we can communicate to them through the educational activities. We can keep a lecture and can allow many people to participate, and you can listen to your talk, and you can communicate to large number of people at one time. So communication has improved tremendously with telemedicine, and that has also improved to some extent the care and control of diabetes patients. It was useful especially in the COVID time, but now, of course, this can be a good tool for the educational activity and also closely monitoring the patients whom you feel are difficult to control, who have a difficulty in traveling the long distances to reach your place. For example, you're sitting in Ongole and a lot of people coming from a distance to you, they might use this idea of talking to you. Okay, now I think we have some more time. Maybe we have quick questions for two more questions, that much time we have. So, what is the better predictor of the glycemic control? Whether it's the prandial sugar, whether it's the fasting sugar, or whether it's time in range measurements, what do you feel is a better predictor?
Yes, sir. This timing range consider both postprandial and fasting glucose, offering a more comprehensive assessment of glycemic control than the individual values measurements, sir. This provides a better understanding of the glucose fluctuation throughout the day. Uh, this HbA1c, uh, if it is more uncontrolled, it's towards more than 9. The fasting value contributes more, and if it is nearing the HbA1c, the glycemic control nearing the 7, this postprandial glucose value measurements will contribute more, sir.
Yeah, I think all these parameters have their own plus points and minus points.
Yes, sir.
Fasting sugar control and prandial sugar control are the point of control the patient can do himself. Time in range requires a sophisticated device to have the good control. I think basically time in range will pick up patients of hypoglycemia, specifically the nocturnal hypoglycemia, which is a very important complication diabetes management. And these nocturnal hypoglycemia can cause sudden catastrophes because in the night the hypoglycemia can bring about QT prolongation and can have arrhythmias and therefore death in bed syndrome. So those can be prevented by very nice, good monitoring these patients. I think every kind of a tool that you use for monitoring patients of diabetes is useful. Everything has its own limitations and all benefits, but overall, all these parameters are useful in monitoring the patients of diabetes control. Now, the medication that we use for patients of diabetes, do they have the adjunct value for the diabetic diet? How much diabetes diet contributes to the control of the patient's diabetes, and whether this is an adjunct therapy to the medication that we use for the patients of diabetes?
uh, Medications for diabetes management, it intends lifestyle changes, and also uh, which includes diet. So complementary to this intervention, uh, balanced diet is a crucial for the glycemic control. The medication prescribed based on the individual's needs. In India, especially in South India, we take a lot of carbohydrates, uh, which will rise the PPG. So we have to address that issue. We have to educate the patient regarding the diet, and we can use either a carbos or oglibos to flatten this postprandial glucose, and also, yeah, uh, those measurements will improve the care, sir.
Yeah, I think dietetic management of diabetes is definitely useful. It does bring down the A1C significantly, say from zero point 0.5 to almost 1.5. But the diet, as I mentioned earlier, is to be one which patient can follow regularly. Whether the patient takes proper medication based on the diet, like some medication should be taken before taking food. For example, sulfonylureas should take before food. Insulin, for that matter, take before food 20-25 minutes. Then the management of diet and the medications for diabetes both work at tandem and can have a good diabetes control possible. So diet does play a role. And when we talk of reversal of diabetes, it's only diet which takes the major role in controlling diabetes. So therefore, it is an adjunct therapy. And when it needs to balance the carbohydrate content, as you mentioned, because most of us consume high carbohydrate, it is up to 150 grams is what permitted. And what we have seen, especially in South India, people consume to 650 grams of carbohydrate. So that carbohydrate consumption has really caused problems on the prandial sugar. We need to change the quality of carbohydrate. All carbohydrate is not bad. We need to have the lente carbohydrate or complex carbohydrate do not bring up the sudden increase in the blood sugar values. Okay, that's again the diet as the adjunct therapy for patients of diabetes. Now, what are the strategies that can be employed to improve the education and the self management skill of patients of diabetes? What are the things will improve? How do you improve the skills of the education and self management?
Sir. strategies including tailored education plans, visual aids, and interactive workshops, and the peer support groups, and also involving family members in the discussion while talking to the patient, and utilizing the technology for education, uh, and the regular follow-ups. These strategies will improve the patient's education.
Yeah, I think education should be such that patients should be able to absorb, assimilate, and use that information so that he has a good control. And for that, it should be provided in such a way that patient comprehends everything that you say. And that can be done by teaching in a vernacular language. Suppose in Andhra Pradesh, Telugu can be used as a medium of instruction to the patient. You mentioned rightly the handouts and also small movies. We used to make a lot of skits during our education program on the World Diabetes Day. We used to make a lot of skits on diabetes. We made a program on Munna Bhai, diabetologist, as one program. Then we have conventional kirtans here. We used to make kirtan, Vasudev, all those caricatures, characters we to enact. The patient themselves is to come on the stage and enact and tell the importance how glycemic control is, how exercise is important, how diet
Yes,
has
sir.
to be followed. So I think it
They
has
will
to
also, yeah, they will also involve in those kids, and
yes,
yes,
yeah,
sir,
and
they
it
will,
inspires. Yeah, it inspires other patients also.
yes,
Not
sir.
only they get inspired, but they inspire other patients. It's like Alcohol Anonymous, where all the group of people come together and they stop drinking alcohol and education about alcoholism. Same thing is about diabetes, and that's what
Yes,
we did, and that really helped. We had A1C coming to close to seven in about 70% of the patients who attended the camp. So that way we could achieve by these programs where we used to have a dedicated full day program for patients of diabetes. So that's my personal experience where we try to educate patients here. I
good, sir.
think we're almost reaching the end of our discussion. Before we close, this last question I want to ask you about the COVID 19 created a lot of dent in the health management of the patients of diabetes in particular and about every disease in general. Now, what is your take on the effects of COVID 19 on the diabetes management and the diabetes complications?
Yes, sir. This pandemic has posed a challenge to diabetes management due to disruption in the healthcare services, first of all, and also access to the medicines, and lifestyle routines also disrupted. So, uh, so that the telemedicine has gained popularity in this period, and bridge the gap in between healthcare and healthcare providers and also patient. So after this COVID, uh, we came to learn that many modalities of many modalities, intermediate, we can communicate with patients. This also helps. Even we can reach the rural population, which are much needed in our support, sir.
Yes, I think COVID did a lot of harm to patients in general and also patients of diabetes. Those who are uncontrolled diabetes at COVID were admitted in the hospital, had a very serious outcome. There was increased mortality. There's also new onset diabetes because of COVID itself. It was to a tune of 16%. Patients had new onset diabetes. A lot of patients had complications, acute complications like ketoacidosis because of diabetes, and that has increased the mortality and morbidity in patients with diabetes. The good control of diabetes was the key, and therefore we learned the art of controlling patients' diabetes remotely. And also, patients realized that if you control your diabetes well, then infection like COVID do not affect them much. I think that was the important message which COVID taught us. COVID taught us a lot of good things, and one of the important thing is to take care of health, so that you don't land up in trouble. So it was a very fantastic discussion, Dr. Hanumantrao, with you. It was a wonderful evening to share diets with you. It was a learning experience to me. I hope it was same with you as well. So before we close the discussion today, the carry-home messages with Dr. Hanumant Rao tells us that the challenges of managing diabetes in this country are vast. It requires a good knowledge of diabetes itself, both by the patient and the healthcare providers. Even healthcare providers should be well equipped to manage patients of diabetes. So therefore, the education forms the most important need of the hour today, and that's the need. And beyond that, of course, the lifestyle modifications of immense value, though it is brushed under the carpet and people do not pay attention to that, because we all feel that you do lifestyle, but nobody teaches about lifestyle. What is actual lifestyle, and how do you adopt it, and how you make it very comfortable and enjoyable? So that is the important clue to make it a successful effort, so that the patient gives a good account to his diabetes career. That's the second thing which Dr. Hanumantrao told us. He told us about the telemedicine, which is an important breakthrough in managing type 2 diabetes using the electronic platform, and that we could reach the unreached, and therefore we could control patient remotely his blood glucose control, and also we could monitor his therapy, and also could introduce insulin therapy to a patient whom it needs. That was again a very important opening in the treatment of diabetes management. He did mention about the barriers and how to overcome the barriers. And Dr. Hanumantarao stressed that it's education, 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 which is the most important aspect in improving the barriers of the lifestyle. And he did mention about how the group activities also inspire patients and also have a good outcome in the controlling diabetes. As we mentioned about the A1C of large population who attend these camps regularly had a good A1C control, and they very much connected, and they got inspiration from other patients, as we see in patients of Alcohol Anonymous. So I think ultimately the bottom line is to keep your patient happy, okay, keep a patient healthy and free of complications. In diabetes, nobody dies of diabetes, they die of complications. If you can prevent complications, you have done a human service to the patient, and that is possible only with a good education and with a good glycemic control and control of comorbid conditions. With that, I thank you again, Dr. Hanumantrao, for having contributed immensely for this 4D education activity.
Yes, sir. Thank you very much, sir.